let's talk about breast cancer after this introduction. Breast cancer is the most common UK cancer, with cases predicted to reach 70,000 annually by 2040. The death figures don't look much better. We had nearly 12,000 between 2016 and 2018, 600,000 globally. But we do know that screening improves survival rates by at least 30%. So let's talk about screening. The gold standard is mammography, followed by biopsies in most cases. But between 2022 and 2023, over 1 million women in the UK did not attend the screening. That's a massive number, and we ought to understand why. In some areas of the UK, the uptake is as low as 51%, Bradford areas, for example, might be here as well, and against the 70% national target. So why is that? And there are actually multiple factors. Let's talk about the sort of most obvious for the women in the room. It can be a very painful examination. It's very invasive. I would say it's quite undignified. That's not something to underestimate. It is culturally unacceptable for some women to have to expose their breasts. Also, the mammographic equipment is not around the corner in all the cities that we live in. So this poses an accessibility problem, accessibility issues for underserved populations. So there are all sorts of issues connected with this, and we ought to find perhaps an alternative screening test or a pre-screening test that alleviates some of this. I mean, let's not forget there's NHS backlogs as well, and we have less radiologists as resources too, so there is quite a lot of issues there. So you now think that this is why then I got from fingerprints to actually look into clinical diagnostics and devising such a test, right? Wrong. Because science, much like life, is never a linear journey. So this was very much a serendipitous discovery. So what I've been doing for 16 years is actually looking at fingerprints at different ways to extract information and intelligence from them. And we all know what fingerprints are used for, and they've been used like this for 100 years. So they used to identify a suspect using the uniqueness of those lines that you see here, the ridge pattern, right? But actually, a fingerprint is something else. And this video, if it starts, which again should start automatically, it does, it shows what it is. And we knew this since 1978, but nobody actually exploited this. So you see a close-up of the ridges, the elevated part of the skin, and those sweat pores from which the sweat comes through, right? And in a moment, you see the lovely sweat, and in a moment, when we make contact between a fingertip and a surface, that's when we leave a fingerprint, right? So a fingerprint is, yes, a pattern of lines, but it's a pattern of lines made up of molecules because sweat is a biological matrix. And in fact, it's not just sweat, it's also all the substances that we pick up, in our daily activities, so the contaminants. The substances that we produce in our body can be excreted through sweat. Those that we put in our body, and that could be food, medications, drugs, anything else, they can also be metabolized and excreted. So really, a fingerprint, for me, I always say this, and I believe it, is definitely the sexier version of sweat, but also it harnesses just a wealth of information that we can exploit to tell something about the individual, right? So we actually developed an existing technology called mass spectrometry, quite a long name there, I'm just going to say MALDI, right? And we measure the mass of the molecules, and not only we detect the molecules in fingerprints, but we can see where they are localized. So you should see in a moment, as we go pick some of those peaks there, and each one represents a molecule, you could see a lovely image of a fingerprint. That tells you that particular molecule is distributed homogeneously onto the ridge pattern. We can do fantastic things with this. For example, we can exploit this concept to separate overlapping finger marks. You see a bunch of those there. We don't know exactly how many there are, but if we do a MALDI analysis, we can then see that there are 6 fingerprints, and we can separate them out. That's because there will be a bunch of molecules that are unique to each of those fingerprints, and we choose to see them in isolation. And so this is very helpful, for example, when you have to separate the victim's fingerprint from the perpetrator's fingerprint, so you can then submit it to the database and identify it. But let's stick to molecules, right? So we coined this term chemical criminal profiling, and really pushing for this to become a discipline, to be maybe an adjuvant to behavioral profiling, right? So by the molecules that we can detect in a fingerprint, we can, for example, infer actions that have preceded a crime or committed during the crime by the perpetrator. And we can start kind of eliminating suspects in our cohort of suspects. We can tell about pharmacological or physiological or pathological states. We can look at personal information. And we can even talk about the state of mind of the individual whilst committing the crime. And it is this bit, the personal information, that for us was very, very interesting. So as we were in 2011 looking at this, we discovered the possibility to attribute a given fingerprint to either a male or a female. We're talking about here biological sex, okay? And we can do this with the 86% of accuracy. And that's because the protein profile of a male is very distinctive from a female, right? And of course, us being scientists, yay, but also who are these proteins? So we wanted to look into what these proteins were. And doing some research into it and further analysis, that was the eureka moment. Some of these proteins were already indicated in the scientific literature as biomarkers of breast cancer, right? So some of these were biomarkers of breast cancer. So you now can join the dots, and I can see your faces, you join the dots now, right? So what if we could develop this method into a non-invasive method to detect breast cancer? A method where, much like you've seen, you can swipe your fingertip on a surface, and we have enough material to detect breast cancer. This was the ambition, the intuition, the idea that we tried to prove. So we did a lot more research. This was 2012. It took me 6 years to be trusted with £45,000. £45,000. So we couldn't do much with it, but I was determined to make the best out of it. So we got 15 women. We published this in one of the Nature Publishing peer-reviewed journals. We got 15 women to come to go to hospital for their routine call mammographic screening and biopsy, so we had diagnosis. We asked them to literally swipe their fingertip 3 times on a metal surface. That was our sample. And we got women from a diagnosis of benign breast cancer, early breast cancer, and metastatic. We then improved our sample preparation. We did a little bit more in terms of making it more efficient and faster, and detecting these proteins in higher abundance and more reliably. And then we did a MALDI analysis. So we wanted to look at those proteins in those fingerprints. And eventually we had 135 samples to look at. And as you can see here, then we did use artificial intelligence. So we did train a machine learning algorithm to learn what a profile of a benign patient looks like, what a profile of an early cancer patient looks like, and so on and so forth. And then we showed the algorithm unseen data and asked the algorithm to actually now categorize the patient. This is that you see on the right-hand side, for the data scientists in the room, is a confusion matrix. That's really, I don't know why they call it confusion matrix. That doesn't sound good, but that is what it is. But the data scientists in the room will see that we have achieved a 98%, well, almost 98% accuracy every time a patient had early breast cancer. We got that right. Every time they were metastatic, we got that right. We had 3 samples, that doesn't mean 3 patients, we had 3 samples that we misclassified. They were benign, and we thought it was either early or metastatic cancer. So that's an example of false positives. But if you ask me, I prefer false positive as opposed to miss the cancer and a false negative. So obviously we've got to work on this. So now, we need to go into large trials. We have to prove the concept, we have to look at specificity, we have to look at different types of tumor and different burden. But if we get these fundings, if we get approved, I mean, the benefits of this test, non-invasive, completely painless, right? Increases accessibility because our idea is to deploy this test directly to GP practices or even to the patient's home. And they have to swipe a fingertip and then post the sample. Okay, so it definitely solves the accessibility problem. Reduces the NHS backlogs because, of course, the hospitals are bypassed, so no more waiting lists. Of course, reduces the impact on the NHS resources because only those patients that are positive to our test progress in their journey through mammography and biopsies. And that is not just in terms of saving the NHS resources, but actually saving the emotional journey to those people that are actually fine. Of course, all of this increases patient compliance. And if it increases patient compliance, it increases the uptake of screening, and therefore we save more lives. But it also enables NHS savings. So we've done some calculation, cost-benefit calculations on the hoof, considering that 1 million women that did not attend the screening, the 58% of the diagnoses that don't come from the breast screening program, including those ineligible patients, and also the stage of cancer and how much each stage costs when it progresses. And we calculated that with this test, we could save the NHS £70 million per year. It is an on-the-hoof calculation, yes, but it's no number on the red bus. Yeah, had to be said. So it always comes down to the patients. I receive lots and lots of letters from the patients, and the relief that they have at the thought that not to have to do mammograms. Please, let's all go for mammograms because it still saves lives. But if we have an alternative or a pre-screening, it really saves a lot of the emotional pain. And I've chosen a couple of those. There are women that can't even have mammography screening because of the size of the breast. That's not feasible. Women under 40, the density of the breast tissue is such that they could go undiagnosed through mammography. And then we have women that just confirm the absolute excruciating thought of having to have that painful process of compressing the breast between the two plates. And some of them even think, if I don't have breast cancer now, I might have it after this, because it's very, very traumatic. And these patients really say, we are behind you, we want to help you, I can be part of the trials, just please tell us what to do. They are the reason why I keep going and I don't give up and try to get more funding to go into larger trials. So the patients are behind us. The NHS is behind us. They've made available their personnel and their resources and their time in kind for us to progress. So now, research councils, what are you waiting for? Thank you very much.
That is really cool, and for lack of a better word. So all this has been off the back of 45K?
Yes.
That's it?
Yes.
Right, that is stunning. So what do you need now other than money? I mean, first, is there a sense of how much more you need to kind of get this to a point of validation or whatever? Yeah,
so if you consider the entire journey that gets you from having the larger trials and looking at all the specificity issues, make sure that those biomarkers are specific for this type of cancer, and therefore you don't waste any more money with a false diagnosis, for example. Mm-hmm. And to the point of the regulatory body that has to approve that, so you have to have all that evidence. So if you consider the long journey, we have calculated about 3 million.
3 million,
but
okay.
Then at the end of this 3 million journey, you also have the kit that you can deploy to the GP practice. So this is considering the whole package. And we are, if the funding came today, we are about 6 years from that point where then somebody will have to say, yes, let's deploy or not.
Wow, okay. So really, in addition to the obvious non-intrusiveness and the ease, and I guess it's something that you could do it, could it be done at homes and things like that?
Yeah,
I mean,
that's the idea.
Right,
that's exactly the idea.
Is it, in terms of the range of detection, in terms of early detection, is it the same as a mammogram, or is it better than a mammogram?
So that's the interesting thing. So, for example, the 3 cases where one of them was actually an early cancer diagnosis, I'm still yet to investigate why that is. And I'm thinking, because this is a molecular diagnosis that we do versus a morphological diagnosis, it could be that this test actually picks it up even earlier than mammograms can do. So I'm worried about that particular case, that we might have got that right, and it was undiagnosed by mammography. But it is something, and I mean, I'm not saying that we should replace it with mammography, but obviously at this rate, if the sensitivity keeps, and the accuracy keeps this high, it's really competitive with mammography. And if nothing else, it could be used as a pre-screening.
As a pre-screen, yeah, of course. Okay. Simona, thank you so much.
Thank you very much.
Really great. Thank you. Take that. Oh.